Good morning, everybody. Welcome to ADRI's first Q&A. We're very, very privileged to have such a fabulous lineup of experts to have on our panel, and we've got a complete multidisciplinary team of clinical experts who are well versed in caring for patients with asbestos-related diseases and particularly mesothelioma. So thank you to the panel. I think we might just hand straight over to Dr. Anthony Linton, who is going to moderate the session. And Anthony is a medical oncologist practicing at Concord Hospital, specialises in thoracic malignancies and lung cancer. He's been very much a part of ADRI from the research aspect and has completed his PhD investigating prognostic factors and new therapeutic targets in malignant pleural mesothelioma. He's been an investigator on many clinical trials and continues his interest in clinical research investigating the influence of asbestos and other biomarkers on mesothelioma development and survival. He's also a network director for physician training at Concord Hospital. So Anthony, thank you. I'll welcome you to looking after us.
Great, thank you, Jocelyn, and welcome everybody. Today's panel is really all about being able to answer some of the common questions that come up for patients and their families after being faced with a diagnosis such as mesothelioma. And as Jocelyn mentioned, we really have assembled a panel that runs the gamut from every step in the patient's journey, with obviously particularly of interest for patients and families with mesothelioma. The other side of things, and that is things to do with what the legal ramifications are and what support structures they can have at a governmental level as well too. So I might start by introducing the panel that we have here today. To begin with, I'll introduce Professor Ken Takahashi. Ken was appointed the Director of the Asbestos Diseases Research Institute and the Professor of the Sydney Medical School in 2014. His background is that Ken was a Professor of Environmental Epidemiology and the Director of the WHO Collaborating Centre for Occupational Health at the University of Occupational and Environmental Health, Japan. Ken graduated from the School of Medicine in Keio University in 1983, and after completing a 2-year residency in surgery, received a PhD from the University of Pittsburgh. He served as a consultant and advisor to the WHO and ILO, and is a board member of the International Commission of Occupational Health and the president of the Asian Association of Occupational Health. He currently serves as a WHO expert on chemical safety and environmental epidemiology, and is an executive council member of the Collegium Ramazzi. He has received the Jorma Rantanen Award in 2011 and is the Selikoff Lifetime Achievement Award in 2014. Ken, if you raise your hand.
Thank you very much.
At the other end of the panel is Associate Professor Brian McCorn. Professor McCorn is a cardiothoracic surgeon with a career-long commitment to passion in the management of thoracic malignancies, especially pleural mesothelioma. He's provided this service for over 40 years at RPA Hospital, Concord and Strathfield Private, and is the chairman of the Clinical Excellence Commission and the Agency for Clinical Innovation, and he's a board member of the Chris O'Brien Lifehouse. Professor McCorn has performed over 8,000 thoracic operations, 859 of which were for pleural mesothelioma, and has performed 140 extrapleural pneumonectomies, which is a lot in a global perspective. Next to him is Dr. Stephen Cow, who is a medical oncologist at the Chris O'Brien Lifehouse. He completed his PhD at the Asbestos Diseases Research Institute and has focused his research on predictive and prognostic factors in malignant mesothelioma. Stephen has a wide clinical, translational and psychosocial research interest in thoracic cancers, including malignant mesothelioma and asbestos-related lung cancers. He was awarded the Premier's Award for Outstanding Cancer Research Scholar from the Cancer Institute New South Wales in 2012. Momo Tin, if she can raise her hand. Dr. Momo Tin is a radiation oncologist at the Chris O'Brien Lifehouse, and she's provided radiotherapy service for mesothelioma since it became available in 2004, and that includes treating every patient who has had an EPP in New South Wales. Dr. Karen Dada is the Cancer Care Coordinator for Manning Oncology and Palliative Care based in Taree Oncology at Manning Hospital, Taree. She's a vital member of the Hunter New England Local Health District Multidisciplinary Team and has a special skill for coordinating consultations via telehealth, connecting patients and families with health professionals in satellite locations, often at the home, breaking down barriers related to isolation and travel. Chris Guthrie is the acting clinical nurse consultant at Concord and Canterbury Hospital's Palliative Care Consultative Service. Her role involves assisting and advising on symptom management for patients living with a life-limiting condition. She's very passionate about improving the quality of life of her patients by providing optimal symptom management and support. Next, I'll introduce Dr. Judith Lacey, who's the Head of Supportive Care and Integrative Oncology at the Chris O'Brien Lifehouse. Her primary interest is the development and integration of supportive care interventions to keep patients living well with cancer independent of prognosis or their stage of disease. Her area of interest is in whole person care, integrating care for people and their families living with cancer or chronic illness that affects their physical and emotional well-being. She works with complementary and integrative medicine practitioners, psychologists, other medical specialists, nurses and allied health professionals to maximise patient well-being. As a palliative and support care specialist, she has extensive experience in managing cancer pain syndromes, cancer-related fatigue, gastrointestinal and nutritional effects of cancer, and treatment-related toxicities. And her research interests and activities are in the field of integrative oncology, medical cannabis, support care service development. Now, Cindy Tan and Jane Turner are valuable members of the Sydney Survivorship multidisciplinary team who support patients and their families to meet their individual needs following a patient diagnosis with cancer. Jane is an accredited exercise physiologist with the Sydney Survivorship Centre at Concord Cancer Centre, where she facilitates exercise programs for patients with cancer, such as Enrich, and provides advice and support for patients wanting to increase or maintain their physical activity after a cancer diagnosis. Cindy is a dietitian at Concord Hospital and is a member of the Sydney Survivorship team at the Concord Cancer Centre. Armando Gardeman is a partner of Turner Freeman Lawyer and specialises in practice in the areas of asbestos litigation and acts for clients suffering from mesothelioma, asbestosis and asbestos-related lung cancer. He joined Turner Freeman in 1980 and became a partner in 1985, and he's played an integral part in creating the asbestos litigation history in New South Wales and Australia, in that he was instrumental in obtaining legislative reforms in New South Wales and has argued for the rights of compensation for individual patients. He's a founding member of the Asbestos Diseases Foundation of Australia and was the inaugural solicitors member for the Dust Disease Tribunal Rules Committee. He prepared the submission for construction and development of a dedicated asbestos diseases research institute housed next door in the Bernie Banton Centre. And all these things, as he quotes, ultimately make life better for injured people. Julie and Sam are from the Dust Diseases Care Eye Care. Both ladies have a long-standing career with the old Dust Diseases Board, now currently operating under the organisation of Eye Care. Julie's the manager of compensation and healthcare services, and Sam is the manager within medical services. And lastly, Karen Selman is a patient care representative and registered nurse who is part of the ADRI team providing support for mesothelioma patients. She brings valuable experiential help to, as well as up-to-date professional information to patients and their families. The fact that that took so long, it really highlights the expertise of the panel that we have here. So we're going to launch straight into their questions. These have been provided by members who treat asbestos-related disease, patients and their families, and there may be some more time for some more questions at the end. I might start with a question for Ken, really talking about asbestos in general. And one of the big questions is the problem of asbestos still real? We've obviously stopped mining it and we've stopped using it in industry, so why do we still care in 2018?
Okay, so the question was, is the asbestos issue still real as of today? And of course, my answer is a strong yes, for two reasons. One, because as everyone knows, asbestos-related diseases, mesothelioma in particular, have a long latency period. That means it takes a very long time for the disease to develop after first exposure. So in essence, for those people who have been exposed to asbestos after the 1970s will have some, unfortunately, risk of developing asbestos-related diseases. And number two, because of the legacy asbestos issue. As we all know, Australia banned asbestos in 2003, but that ban applied only to existing asbestos. So there was no, Australia effectively banned the new use or production of asbestos, but the asbestos in situ, we call it, remains in our community. So there are opportunities for, well, essentially many people to get exposed to asbestos. So that means there is a potential risk of developing the disease. Now, if I may add just one caveat, if we look across the world, there are still many countries that consume asbestos. Many countries do not have a ban on asbestos, and several countries continue to mine asbestos. So the quick answer to your question is yes, asbestos remains a serious issue in this world today.
Now, when someone does get a diagnosis of mesothelioma, one of the first people that they meet often is the medical oncologist or the cardiothoracic surgeon. And one of the common frustrations many patients have is that a diagnosis takes so long to get that it can span many months. I might ask Stephen and Brian, why is this such a problem? Why does it take so long to get a diagnosis?
Look, I think the symptoms related to particularly early mesothelioma can be quite nonspecific. We all know that common things occur commonly. So when people are coughing or having a bit of shortness of breath, people obviously think of common. Is this on? It is on. Sorry. I'll just put it closer to my mouth. So I guess common things occur commonly. So, the GP obviously would think about perhaps a chest infection or pleurisy and treat it as such initially. So I think, there are a couple of issues here that, symptoms are not specific. And I think the second thing is that really people need to have a high level of suspicion when people present initially.
I think that's true. The other issue, of course, is that when patients present with a pleural effusion, which is the commonest presentation still for mesothelioma, people will often do an aspiration of fluid. And because it's negative, people will foolishly take solace from that. Like all needle biopsies, negative doesn't mean negative. Negative means we haven't proved it and should take the next step. There is absolutely no reason in this day and age there should be a delay, because they should proceed, and it's certainly our practice, as opposed to some people who are, still remain strangely enamoured of tubes in the west of Australia. They should proceed to a thoracoscopy, a keyhole operation, where actual tissue is taken, an assessment can be made, and an effective pleurodesis. So it's being aware early. But one of the reasons is, when I first started working at this hospital, many years ago, saw a patient who'd had 27 thoracocenteses, that's taps of the fluid, 27. I suggested to the professor of respiratory medicine at that stage, we should do something definitive that may actually help the patient. And that's when we really started being much more aggressive in terms of what we did. And that was before thoracoscopy. So in fact, you have to get them to a person who's interested in making the diagnosis rather than excluding other things.
Now we know from other cancers, including obviously lung cancer screening studies, that patients with early disease can potentially be offered curative surgery and can have an improved overall survival and potentially cure as a result. Is it the same for mesothelioma?
I have never said to a patient with mesothelioma, I'm going to cure you. I just don't believe that's a fair thing to say to them. I said myself and the team, which includes all the people here who work with me, are going to make you better in terms of as long as we can. One patient of mine used to take great exception. He used to come to all my lectures when I'd say I've never cured a mesothelioma, and he died 14 years after a pleuropneumonectomy, and he died of pneumonia in the bad flu season last year. I went to his funeral, and there were 5 others there beyond 10 years who'd had pleuropneumonectomies. So there are some patients, and it's the exception, not the rule, and I emphasise this. For me to say everyone should have a pleuropneumonectomy is as crazy as the medical people saying no one should have it. Of all the patients I've done with meso, about 15% are suitable for consideration of mesothelioma. They're not suitable on grounds frequently of their age and their medical condition that would not tolerate a pleuropneumonectomy, or their disease is not suitable for it, and we've all had that. And I know there's some examples here today where that's happened, where the nature of the disease precludes you. I don't think the issue in the great advances we've made in helping patients with mesothelioma has been focusing on cure. It's been focusing on looking after them, which didn't happen before. And I'm totally dependent on all the other people I work with in this. It's not a surgical proposition alone.
So Brian, if cure is obviously the exception rather than the rule, and long-term survival is the exception rather than rule, what's the point of trying to identify patients with minimal disease at an earlier stage if there's no nationally accepted treatment pathway?
There's no evidence at all. We have recent evidence from the big American study recently on screening for lung cancer in high-risk individuals, a 22% reduction in overall mortality. There is no evidence for screening for mesothelioma. When the governor, one of our governors, died of mesothelioma, a naval man, it was proposed to us here that we run a screening program for all naval people who'd been exposed to asbestos. Professor Breslin then appropriately indicated we'd be delighted to run that screening program for naval personnel, but what we'd be looking at is actually finding lung cancer, not mesothelioma. The aim in finding patients who are suitable for pleuropneumonectomy, and our results in conjunction with Stephen, where they have induction chemo first and then momotin, where they have IMRT afterwards, is we've shown a very significant improvement in survival, both in terms of quality and quantity, which has then often allowed the patients I've done to have the new treatments as they unfold, often out of ADRI. And they're the patients who benefit greatly. And I have a number of patients now following pleuropneumonectomy who have disease, but who are being managed with the new agents as they come available. That's the reason to see it early. I don't believe there's a role for screening though.
So patients, because we aren't talking about cure often, are often given a prognosis at the end of the day and being told, well, maybe they've got 8 months or 10 months or 12 months to live. And for some patients, that use by date that they've been given comes and goes. What does this mean, Stephen? Why is it that we can't accurately predict prognosis?
Well, look, I think that problem is really not alone to mesothelioma. I think prognostication is always difficult in oncology because, even though, we know that there's mesothelioma, we know, there's a whole lot of different factors that contribute to how people go with their disease, as well as treatment, including histology and how well the patients are and whether you're male or female. But beyond what we know, there are a lot of unknowns about why people do particularly well and people who don't do very well. And I think discussing prognosis is always very difficult. Often, as you said, people hear a median months or survival and people start counting backwards. And I think that's not very useful at all from my perspective and from patients' perspective. And so I think really it's important for patient to know that it's very variable and some people do extremely well it's about trying to get the best treatment possible and if surgery is part of it then I think that's something to consider as well.
When I was a little boy at school, my mother developed ovarian cancer in the days when there was no treatment for ovarian cancer. the very caring gynaecologist who had polio himself came to our house and said, "Beryl, you have 3 months to live." My mother turned to me, a very strong woman, and said, "Doctors do not determine how long we live." And that was a guiding light to me. And she lived for 2 years. Doesn't sound a long time, but for a boy at school, it was a lot longer than 3 months. Doctors do not determine how long people live. We've only heard on the news over the night about exercise, and we've got someone here who's an exercise expert about how that improves it. My aim in treating mesothelioma is to let people live the life they want to live. I never talk about prognosis, and I tell them to ignore all that's written. They'll determine how long they live. Just give us a chance to help you live that way.
Look, we all have patients who come into our clinics who have heard from the media or have heard from the internet or have heard from our colleagues that nothing can be done, and you go home and you get your affairs in order. What does this mean, and how much should they believe it?
Well, they shouldn't believe it. I mean, I always tell them, I'm sure, and it's usually when they have daughters, and Jocelyn thinks I have a problem with daughters. I have 2 delightful daughters. The daughters have gone on the net, and they're sure that people say they're all going to be dead in 12 months. Well, they're just not. It's a spectrum of disease. One of our favourite patients of Jocelyn mine's an artist. My house is full of her art. She never had any treatment other than talc pleurodesis. She declined any other treatment. She just wanted to travel the world and paint. She died 10 years after the diagnosis. Each year her pleura got a bit thickened. She definitely had mesothelioma, but she got on with life. And I said, "You don't have to come and see me every 12 months. And she said, "I'll get sick if I don't." I mean, you've got to let people decide. It is a spectrum of disease. Some have bushfire disease and they're dead 3 months after it's diagnosed. There's no doubt. But it is not one disease. It's a spectrum of disease. Let them live their life.
I guess the challenge, and come from a palliative and supportive care background, the challenge is the uncertainty, and people are living with a huge amount of, listening to Brian now, is you're living with a lot of uncertainty as to, is yours the bushfire disease, is yours the disease that's going to be quite slow? Mesothelioma isn't just one disease, is that fair to say, Stephen? And so it's working out strategies to live with that uncertainty, and that uncertainty regarding prognosis, the uncertainty as to, is this treatment going to control my disease? For how long is it going to control my disease? Is there another treatment, if I stay well, that I'll be eligible to have? And so a strategy to maintain and people's well-being and help them live with that uncertainty is really good symptom control, really good support services that improve quality of life, so that every day is fantastic. And if you are well and fit, then when the opportunity comes for a potential trial or a new treatment, or the disease is progressing, then you are in a state where you're actually eligible. And that also helps. Knowing when, spending, I guess, years or months preparing for dying is not necessarily the best way of living, and it's acknowledging your advanced care directives, talking to your family, knowing that your prognosis may be poor, but living in the hope that you'll be that other person that does really well, and working towards staying as well and as fit as possible. And we know that with good supportive care you can actually live longer, particularly with disease in the thorax.
Now, we know from other cancers, we have a patient who is diagnosed with breast cancer, and it often feels to them that they come for their consultation and there's a very clearly defined pathway where you have surgery here, you have radiotherapy here, you have chemo, hormonal therapy, and everything is quite standardised in that sense. Now, perhaps because it is actually many diseases in one, mesothelioma patients often feel they may have to have a very active role in deciding, well, do I be observed? Do I have chemotherapy? Do I have immunotherapy? Why is that?
Well, I guess it's because they don't go to centres where that guidance is provided. We have an algorithm for managing mesothelioma just like breast cancer, absolutely no different. I mean, the dilemmas about whether to have treatment, my wife died of breast cancer a few years ago. The dilemmas at each step about treatment are still there once it is metastatic. I don't see the difference. If you come to see me with mesothelioma, there's an algorithm of treatment that we have in conjunction with my medical and radiation oncology colleagues. But I do share very much the importance about palliative care and supportive care. I think it's a critical part in mesothelioma, but no different to breast cancer. Some of the most important aspects of breast cancer care is supportive care as well. So in our hands, the problem at the moment is no one was interested in mesothelioma or treating it for many years. It was better then because they all came to us. Now everyone seems to want to have a part of it, and it's being managed in some parts by people who don't have that expertise, knowledge, or years of understanding this disease. We have an algorithm, just like breast cancer.
So is there a tool for clinicians and staff to help evaluate the risks of side effects of treatment versus the benefit of these treatments that we might offer?
Well, look, you're talking about a specific tool or algorithm in which we make decisions.
How do clinicians, how do you weigh up the challenge between managing the toxicity of treatment and being able to recommend a treatment that you know have side effects versus what the potential benefit could be?
Looking away, it's really a little bit of an art in terms of chemotherapy. There's no precise factors that's 100% predictive of how well patients are going to go. We've got some general rules, you know, if you're younger, people do better or tolerate chemotherapy better. If you're physically fit, you're going to tolerate chemotherapy better as well. But to put a precise risk of how patients are going to go, you know, what is the risk of you getting really sick with chemotherapy versus what is the percentage of benefit, you know, to precisely predict that for an individual patient, I think it's still pretty impossible at this point in time.
Now, Stephen, our chemotherapy that we do use at the moment has been around for a long time. What's new in the pipeline? What's exciting? What's changing in mesothelioma that you can prescribe now that you couldn't before?
To answer that, exactly that I can prescribe, probably nothing. But we have to remember that those chemotherapy evidence came from 2003, and for over a decade, it has not changed. But I don't think that all is lost. I think recently there's a couple of trials that have suggested that blocking blood vessel as a strategy in mesothelioma looks quite promising. So there's a trial that was reported a couple of years ago using a drug called bevacizumab, which is a way to block blood vessels in conjunction with the chemotherapy that we use, looks better than simply using chemotherapy. And similarly, I think that proof of concept is proven by another clinical trial using an oral tablet called nintedanib, and that, again, is blocking the blood vessels as a strategy in conjunction with chemotherapy. And similarly, that looked pretty promising as well. So I think as a strategy of blocking blood vessels is going to be promising, but at the moment it's not PBS reimbursed as yet. And I guess the other thing that everyone is interested in is obviously immunotherapy. It's shown great promise in other solid organ tumors such as melanoma and lung cancer, and as a result, there's a lot of interest in using immunotherapy in mesothelioma. Now, there's some very early evidence to suggest that for a small proportion of patients, it's very useful. And at the moment, we're really exploring the role of it. Should we be using it singly, or should we be using it in combination with chemotherapy? There's a lot of clinical trials that's been conducted, and hopefully in the next few months to a year, we'll have some more answers. But at the moment, based on early data, if you're a client of Dust Diseases Board, we can apply for that on an individual basis.
Okay, so this really raises that awful prospect of money, and every patient who has cancer is affected by the financial strains that it offers, and yet for many patients, chemotherapy is a relatively cheap PBS script that they may have to pay a small fee at the end for some supportive medications. But these treatments are thousands and thousands of dollars. And I guess this is where we bring in our lawyers and bring in our dust disease care people. Who is entitled to compensation, and what makes mesothelioma different from all those other cancers in that this plays such an important role in their care?
There are multiple schemes all around Australia that deal with compensating people who have mesothelioma. Because we are a Commonwealth, every state has its own legislation. Some states have lump sums that they award on diagnosis. Other states have statutory schemes. In New South Wales, we're very fortunate. I've long said the compensation scheme that we've got in New South Wales is the best compensation scheme that we have in Australia. If you're a worker and you've got mesothelioma and you've had an exposure to asbestos dust, you qualify. And the quicker the diagnosis is made, the quicker you get onto the scheme, the quicker you get the benefits. And I guess that all comes back, and if I can just delve into the medical for a moment, Dr. Linton, with what Professor McCorn and Professor Cow was saying, early diagnosis is absolutely critical. And all this mucking around with fine needle aspiration biopsies drives a mesothelioma litigation specialist around the bend because there's months and months of delay in arriving at a diagnosis, and all of that delay impacts upon people's entitlements to get their statutory scheme entitlements through the Dust Board organised, and it impacts upon their capacity to litigate their common law actions at an early stage so that they can maximise compensation recovery and they can use the money to get a better life, to do some travelling, to do whatever else they might want to do. With workers, it's not a problem really because they go through the Dust Board and they have their common law entitlements. The more difficult cases are those that occur through home renovations, children's exposures. They're all outside the scheme, so they all become common law actions. And we call them the third wave actions. The clients, patients are invariably younger. The group has a greater number of women within it than what the employment group has. In my practice, since about 2000, I would estimate that about 20% of my current clients these days are women, exposed either during the course of home renovations or exposed as children from playing around material or being present when parents were renovating. Those people, where a defendant can be identified, have common law actions, but I think going forward, perhaps over the next decade, as we move past what Professor Takahashi called that 1970s, 1980s period, we're going to get more and more people who are going to be incapable of identifying a defendant. And at that point, there'll be a very serious challenge for government in Australia as to whether we set up a scheme, not just for workers who've been exposed, but also for people who've been exposed outside of occupation who can't identify a defendant. The British have already set up such a scheme. I think it's only a matter of time before we go in the same direction.
So what happens now? I come to you, I've been exposed as a self-employed person or because my partner, was impacted in some way. What do I do? What's the steps that I take?
Well, if you were exposed as a self-employed person, say working in the building industry, there are provisions under the Dust Act where people can be deemed to be workers and they'll go through the scheme and they'll have their common law action. If the exposure is wholly outside of employment, if the exposure is completely within a home renovation type environment, then you've really got to identify the manufacturer of the fibro material that you worked with. And that's actually not as hard as it sounds. After a while, you develop a fair amount of expertise with the sorts of products that the different manufacturers manufactured and put on the market. It's remarkable what you can do with a 2-inch cover strip. Tells you a lot. You can work out who manufactured it, and it gives you a cause of action against one manufacturer as against the other, because the other one didn't make a 2-inch cover strip. So a lot of it really comes down to, it's just the same as in medicine. You've got high-level experts who deal with mesothelioma. They actually get the best outcomes, and in the compensation field, people who have expertise in the area, who work in the area, have a huge amount of information. They invariably get better outcomes.
Some patients obviously worry, particularly when their diagnosis has occurred late and they've been referred across to things like DD care late. Does anyone from Dust Disease Care talk to the patient or their family about what they do when things unfortunately do come to a head and they do pass away? And is there a practical guide for them about what to do then?
Thank you. Yes, look, we have a very streamlined application process, and since about August of last year, we've actually got liaison of... Is that better? Oh, thank you. So as of August last year, we've got liaison officers who are single point of contact at Dust Diseases Care. And so if anyone is in that situation, when they call through, they'd be put through to those officers, and they would be able to take all the information over the phone and be able to go through the application with you without you actually completing the application yourself. And they can also work within the business at iCare, collecting information from your treating physicians and working in with Sam's team, who's sitting next to me today. Sam's from the medical services area, and we've actually been able to reduce our timelines now from something like 62 days down to just under 20 days. So we've had significant improvements in those service lines. And I'm not sure if you all know, we've been in existence for 90 years, and we spoke to a lot of our workers and their families, looking at how better we can support them, and what we identified was the processes were taking too long. So the client liaison officers can actually, they can hold your hand through the process, and even when it comes to that situation where the worker has passed away, we can transition the family members into the dependency application process as well, and ensure that any entitlements and benefits will be finalised and paid out in a timely manner. We've
already talked a lot about the importance of palliative care for a diagnosis for a patient who's been diagnosed with mesothelioma. Now, Judith, the words palliative care and supportive care and end-of-life care, they're all very confronting. Are they the same thing?
I think, so I'm very into names and changing names to improve care for patients. I think we see worldwide that the term supportive care encompasses both palliative care, rehabilitation, as well as survivorship. So supportive care is the support of people who are receiving treatment, whether it's disease-modifying treatment or treatment to purely control their symptoms, or curative treatment to keep them living well with their diagnosis and their cancer and improve their quality of life. Palliative care is defined quite similarly, but it's primarily for people with incurable disease from the time of diagnosis. And the funding of palliative care services is often more limited to people who, and it depends on where you live, what state, what country, as to how the resources to a palliative care service are provided in, but generally the palliative care services are from the time of diagnosis with an incurable disease, and that includes a multidisciplinary approach to keeping people well with their cancer and caring for them at the end of life. End of life care is very, very important to get well and to have specialists involved in end of life care and prepare people for end of life care. We're usually quite good at prognosticating end of life in the last month or so of life. Before that, there's a lot of uncertainty around it, but when people start changing, we're pretty good at telling you how long you have. That's just from the studies, but end of life care with good symptom management can be, and good preparation is an important part of supportive care. The name palliative care scares people, and so if we change the name, does that improve the care that is being received by patients? And the answer is probably yes. So I call myself supportive care, and I see other people as well. I see people who have got really bad nausea or fatigue during their breast cancer treatment. But I also see people who have an early diagnosis of mesothelioma, who may have pain syndrome, shortness of breath, could benefit from exercise, nutritional consultation, good pain and symptom control. So changing the name probably makes a difference. The care is the same.
Now, Chris, nurses in the community and nurses in the hospital are very much at the front line of many of these discussions as well too. How do you find the best language to use in patients when talking about these difficult things associated with palliative care and what will happen at the end and what things will be like perhaps when they die?
I guess, well, the main thing is that we always use honest language. We always speak the truth. We don't like to say things that we're not absolutely sure of. So when we're speaking to families and patients, if we're asked a question, we'll generally give the answer. So if we're asked how long do you think we've got, then we'll try to give them ballpark figures, whether we think it's days, weeks, months. It's done with as much feeling as we can, because we understand that this is a difficult time and it's hard to accept that life is coming to an end. But we also make sure that we put in place every single service that we feel is available for them. So things like peach packages where people can come out to your home and care for you at home. So there are a lot of different services we can put in place. And we don't want you to feel abandoned. We'll make sure that there's always someone that you can contact or some way that you can be helped through the symptoms and the course of dying. And we will actually explain what dying might be like. I just don't think open, honest conversations, just being there when they're needed.
Now, Judith, patients will come and see clinicians and they'll be recommended treatment XYZ and there'll always be perhaps diminishing returns on the way through. Is it okay to say you don't want more treatment or that you've had enough?
I think it's always really important to know when you feel you don't want to have more treatment and when you've had enough. I also think it's really important to speak to your treating specialist to check that they agree with you and they're comfortable with your decision. Some people say they don't want to have any treatment and then change their mind after a couple of months, and that's also okay. But definitely it's really important to stopping disease-modifying treatment, particularly if it's not working, is appropriate for many people. But that doesn't mean you stop trying to stay well and improve your quality of life. So really good symptom management is incredibly important. Exercising, staying as active as possible, eating as well as possible, all of these things are incredibly important and may work almost as well, if not better, than some treatments that are not controlling the disease. So it's really important to maybe not have, if you decide not to have a disease-modifying treatment and you've discussed that with your treating team, that really good supportive care and really good lifestyle change, significant lifestyle changes can still improve your quality of life with mesothelioma.
Now, pain is one of the big issues that mesothelioma patients face, and part of the collection of medications that we prescribe are pain-relieving medications, and there's a whole bunch, and there's Targin and OxyContin and Oxynorm and Lyrica and so forth. Why is it that there's so many options? Are there different sources of pain in these patients?
Mesothelioma can be quite painful, and it depends on the site of the disease. It's often a mixed pain. We've got a lot of drugs in Australia. We are very, very fortunate. Not every country is as fortunate as us. We have multiple opioids. So when you think of Targin, OxyContin, Dilaudid, oxynorm, morphine, endone, all of these drugs, fentanyl, they're all similar in that they're all opioids. We have a lot of anti-nerve pain medications because mesothelioma can often cause a nerve pain, either a sharp stabbing pain or a hypersensitivity. When you touch your skin, it actually hurts, can resemble shingles in that way, and that you get a burning sensation. If a woman wouldn't want to wear a bra, you don't want to be hugged, and that often is a mixed nerve pain which can respond to quite well to anti-nerve pain medications, and we've got quite a few of them, and it's getting and then there's an inflammatory pain often with the inflammation of the pleura, and sometimes disease that presses on the bones as well. So addressing each aspect of the pain, and it's really like getting the recipe right, because the most important thing is that you have good pain and symptom control, that your head is really clear, and that you're not sleepy, and that you're functioning well. And it's when you and seeing a pain specialist or a palliative care specialist, a supportive care specialist, or a GP that really knows what they're doing to get that right is incredibly important.
Now, one of the big issues, particularly over the last 12 months, has been a real discussion around medical marijuana and cannabis, and, you know, it goes on the full spectrum from it's the worst thing in the world to it's the thing that's going to cure your cancer and solve all your problems. How hard is it a process to prescribe marijuana, and really, at its heart, does it work?
So we don't know that cannabis, we have no evidence to say that cannabis controls cancer, and we can't prescribe cannabis to control cancer. So that's as far as prescribing. We have quite strict regulations as to what we can prescribe for. So refractory pain, which means after you've gone through all these medications and you've still got pain, cannabis may be helpful. For refractory nausea or loss of appetite, which is common in cancer, again, after all the standard medications have been used and you're really struggling with persisting nausea, loss of appetite, then cannabis can be prescribed. If you fit the indications, it's very easy to get through the new TGA program and prescribing. So if the right person, if it's the right indication, it may need a few visits to the doctor to try all the other medications. If there's an indication, then cannabis can be prescribed, and the approval can come between 2 hours and 3 days. So the next thing is to have a chemist that is able to supply it, and then be able to see your doctor regularly to monitor and adjust the dose. Does it work? Not for everyone. Is it without THC? No, it's with THC. The THC is the bit that makes you stoned, and not everybody likes to feel that. People think that cannabis, if it's medicinal, doesn't make you feel, doesn't have any THC in it. And all the indications that I've mentioned all do have THC, but it's in different doses, so it's adjusting the dose and seeing specialists that know how to prescribe it well. New South Wales Health also has the Compassionate Access Program, which still exists, which means anyone with terminal cancer can receive a certificate that may give them some protection from the police not to be arrested for accessing cannabis from an illegal source, and then prescribing it in that way. And that has been a route that some people have taken. You can't drive when you're using cannabis, and taking cannabis, whether it's medicinally prescribed or sourced elsewhere. So it's an interesting field, and we're learning every day.
Okay. Brian?
A number of my patients remain lifelong friends as well as patients of mine, and every so often they do open up about what they get up to. They have no trouble accessing cannabis. I don't have to prescribe it. And a number of them relate to me that they get benefit from it, and it makes their life all worthwhile. So it is freely available, as I'm sure our children would tell us.
Now, a lot of what we're talking about is what things people can access in the hospital and in healthcare centres. Does disease care personnel provide actual hands-on care to patients and carers in a local community sense, or do they engage with services from the local community?
We actually don't provide the care at Dust Diseases Care. However, we've got a panel of providers, particularly with home care. That could be registered nurses or hands-on care in the home for personal care or domestic assistance. So they go through quite a stringent process to get onto our panel. And we've just reviewed and renewed our panel on the 6th of February. So we've got service providers that go across Australia, but mainly in the states of New South Wales, Queensland and Victoria. That's where most of our workers live. And it's just a matter of contacting us and we can then put those services into place. So the answer to that question is no, it's not actually the Dust Diseases Care staff. We've actually got providers who do the services for us. And we've also got a tool that we launched late last year called a My Plan. And what that does is identifies with the worker what supports they need in their home and what support they need for their family as well. And it's really about person-centred care and what's important to them. And we've got different modules within that tool. And it can also look at end of life, and it's actually called My Affairs. So that's something that we actually offer now.
And do those services that the DDC engages with, does it vary between health districts and more importantly, does it vary between rural and metropolitan areas?
What we find is it can vary because there's limited service in some of the regional areas. And particularly in the remote areas, we do struggle at times, particularly finding occupational therapists and working with GPs, particularly in getting the appropriate services into their homes. So we do struggle. There's a gap in those remote areas at the moment. But we're trying to work closely with the GPs and with this My Plan tool, and also the palliative units in the local areas. If our workers actually register with those palliative units, it's actually it works in favour of the worker because then they could connect with our carers that go into their homes, and then they can work collaboratively in providing care.
Now, we've talked a lot about medications and we've talked a lot about nursing support as well, but exercise does play a really key component of it. And Jane, you work a lot with this. A recent comment on the radio talked about in the context of mental health that when you don't want to exercise, that's the time that you really should be doing it more than anything else. Does that apply to the cancer context, and does it apply to oncology, and does it apply to supportive care and surgery and radiotherapy?
Thank you. Yeah, this is quite topical at the moment, and I guess it's no secret that exercise is great for a whole host of health reasons: heart disease, diabetes, mental health, and now specifically moving into the oncology field. So it's been mentioned a few times this morning, overnight, and today there has been a launch of a position statement which encourages and calls for exercise to be a part of standard care for all people diagnosed with cancer, no matter what stage and what type or what stage of disease. Now, the question here that we get a lot is what type of exercise is the best type of exercise? How much exercise should you be doing? Now, we've had exercise guidelines and recommendations around since 2009, and the first priority that it calls for is that once you have been diagnosed with cancer, no matter what type, is that you return to or remain as physically active as you are able to. So I guess the point of that is that you refrain from being as sedentary as possible. So we know that resting is now probably the least beneficial type of activity that you could do. So we want you to be as mobile and as active as possible. Now, if you're able to do that, there are now 2 different types of exercise that are recommended. And so the first one is aerobic exercise, and we encourage people to progress towards 2.5 hours a week of aerobic exercise, and that includes things like walking, cycling, aqua exercise, dancing, anything that you have a noticeable change in your heart rate. And that can be done in as little as 10 minutes at any one time. So 10 minutes at any one time is going to have a positive impact on your health from a cancer perspective. The second thing that they ask you to try and do is resistance exercise, and this is the type of exercise that sometimes gets forgotten, and this is the exercise that helps to maintain or rebuild your muscle strength and mass back up. They recommend that you do this 2 to 3 times per week if you are able to, and there are exercise specialists out there in the community now and in hospitals who are specifically trained in dealing with people who have cancer and the types of treatments and side effects that come along with that. So in terms of mental health and, you know, when's the best time to exercise? If we use fatigue as an example, fatigue is quite common with all different types of treatments with cancer. And so there is no best time of day to exercise. If you wake up in the morning with the most amount of energy at that time of day, then that time of day for you is the best time of day to try and be as active as you can or participate in exercise.
So Jane, how do you encourage patients to be able to turn on that desire to do exercise when really it's the last thing that they want to do? $1
million question, really. I think motivation is always a key no matter what, you know, walk of life you're from. But it's Dr. Cowell said this before, the more physically fit you are, the better you tolerate your treatment. So we do have what we call level 1 evidence now for exercise as the best way to manage your fatigue. So if that is the one thing that is bothersome to you at this point in time, you want to be able to improve your fatigue, which will then hopefully improve your quality of life and the ability for you to be able to do your normal activities of daily living to your best ability, then we need to try and help you to get as active as you can, and that's going to be different for everybody. And that's why the exercise specialists are there and available now through hospital and also through Medicare and through GP, and you can access these specialists through Medicare for free, and they will find the best way for you to start or restart back into an activity plan.
Okay. Now, when we talk about exercise and fatigue associated with that, we also often, patients have the flip side where they experience poor appetite and feel tired as a result of having a reduced oral intake. Losing one's appetite is obviously one of the most unpleasant things that patients can actually experience, and carers often struggle to find that balance between the need to eat and having no desire to eat. Cindy, what's your advice to patients and carers who deal with this dilemma?
I think it's commonly seen in patients, especially when they are on treatment. I guess that the simple answer to that is really to see a dietitian. I guess the role of dietitian is really to actually give you some dietary advice, how we can actually improve patients' oral intake while their appetite is poor. Sometimes we can actually recommend some oral supplement drinks to reduce the stress of that they have to eat certain amount of food. Sometimes it can be simple as just have an open discussion. I guess that a lot of people have these expectations for both family and the patient themselves that they have to eat certain amount of food. Whereas we know that during certain time of their treatment journey or cancer journey, it is very difficult to have the certain amount of food they used to have. So I guess having a discussion, not talking about like supplements or any dietary strategy, just having a discussion between the family and the health professionals and looking at what we're trying to achieve there. Because it can be just a simple strategies like eating small frequent meals. It can be just saying that, well, you know, if it taste is a problem, then actually having other strategies to actually improve the taste. Or it can be saying that it can be a temporary things where we actually say we may have to accept the fact that the taste is no longer the same. I guess some people are very much affected by the taste change, and some people said, I have to eat because it's for living. I guess that's where we actually come in as a dietitian to really have this discussion, actually provide some strategies to help. Certainly, it also depends on which stage of cancer journey they are. Sometimes at the end of the cancer journey, eating, we actually say we have to eat this amount of food, and so that we don't lose any more weight, so that we can keep it up. I guess it's important to actually remember one thing. Eating and drinking not just about meeting the basic requirements, but also about enjoyment. We really want the patient to actually stay well and eating well, do the things they can do. At the same time, we also want them to enjoy the life with their family members. We know that in our daily life, a lot of our social activities go around the eating and drinking. So sometimes it's not about just say, I have to eat this amount of food, but it can be say, I eat some amount of food, but I enjoy the time with my family members.
Cindy, obviously some patients can't always get to see the dietitian, and particularly in rural and regional areas, they may not have the services available all the time. Are there resources or websites available to patients and carers?
Yep, I will recommend Cancer Council. They actually have a very good websites on different resources about the tips on how to eat better or symptom management. But they also have one particular website I would like to mention is iheart.com.au. They actually talk a lot about complementary components, and you can actually submit the questions as about different food and things. They actually have professionals to actually answer your question. Apart from that, I think that another website we often forget to mention is about Dietitian Association of Australia, where they actually list all the private practice dietitian in community. If you don't have access to a dietitian in the public setting, certainly the Medicare do actually cover your visits to the dietitian as well. Nowadays, there are some telehealth. Some dietitians do provide telehealth consult as well. You mean the Dietitian Australia of iheart.com.au? Yes, so it's iheart.com. iheart, H-I-H-E-A-R-D. iheart, yes, iheart.com.au.
Now, these challenges for patients, particularly in regional settings or rural settings, are very real. We've published research here at ADRI that shows that rural and regional patients don't access chemotherapy and surgical interventions and radiotherapy as much as their counterparts in metropolitan areas. Karen, how do you find things in the Manning area? Do patients have the same access to expert knowledge, and will they receive the same care that their friends in the city do?
I think living in a rural area, it's a lot harder to get in to see a GP for a start. It can be up to 6 weeks just for an appointment to see a GP up there. We only have one area that bulk bills, so everyone's having to pay to see a GP. Then you could be referred on to have a scan, which could be another 2 weeks before that happens. If you're going to have a biopsy under that scan, it could be another 10 days. If you're going to be referred to a physician, it could be 3 weeks. Then if that physician is sending you down to see, you've got to go out of area to have a VATS pleurodesis. So that could be another stress on the patient, which could be another couple of weeks. You're taking them out of their own home environment. They may not want to go because they may have a farm that they have to look after and can't find anyone to look after that farm, or they may be the carer for someone else who's sick, or I suppose it's the same sort of thing in the metropolitan areas, but it is putting another extra strain on patients. We do have a oncology unit up there that we do chemotherapy. We do give chemotherapy. It's a couple of week wait to see our medical oncologist at the moment, but we also are doing a lot of telehealth medicine. So for patients to travel for surgery or for radiotherapy, our closest radiotherapy is an hour away, which is in Port Macquarie. But we fall in under the Hunter New England Area Health Service, and Port Macquarie fall in under Mid-North Coast Area Health Service. So neither oncology medical records connect because they use Mosaic, whereas we use ARIA, which is where we can actually see what's going on down in Newcastle, but we can't see what's happening with our patients up in Port Macquarie, which is only an hour away. So we use radiotherapy telemedicine. the patients travel for their radiotherapy, but then for their follow-up appointments, we can actually use it for with telemedicine, where the patients come to the oncology unit with one of the cancer care coordinators and connect up with their radiation oncologist, whether it be in Newcastle or in Port Macquarie, so they don't have to travel, especially for pain management. With our palliative care service, we actually have a service of nurses where we can actually do a nurse referral, or anyone can refer to palliative care. The nurses are there. It's a 7-day-a-week service. We have after hours where they actually have a number that any of our patients can call, and it connects up with the palliative care nurses within the hospital. We are doing a lot of telemedicine with the palliative care specialists down in Newcastle. So if we're having issues with pain management and the GPs are struggling with what pain management can be given, then the palliative care specialists can be involved. We give chemotherapy 5 days a week in Taree, so patients travel into us. Our area, the furthest away our patients travel is about an hour and a half to get to us. Yeah.
And Karen, what's the patient experience with telehealth now? How real does it feel to them?
Fantastic, I have to say, because a lot of the time I'm in there with the patients, and I do encourage the specialists to use the coordinators in the oncology unit, because we're there with the patients and we can feed back to anyone else who's being involved, so allied health, palliative care, and GPs. I know there's a lot of Skyping that goes on between specialists to GPs, and then we actually miss out in the oncology unit if we're the ones that are giving the treatment. So the patients are loving it because they don't actually have to travel out of area. After we've had the teleconference, if they're not too sure on something that's said, we can go over it again. And if there's another question that the patient's actually wanting to know, which they've forgotten to actually ask the specialist, I usually email them down and ask that particular question, and we can get it straight back, that answer.
No, I did Dubbo outreach clinics from a medical oncology perspective for a number of years, but we didn't have a PET scan and we didn't have radiation on site and we didn't have a cardiothoracic surgeon like Brian there. So I'd be commonly sending my patients down to Sydney to receive the care that they needed. But this all, it all adds up and it all gets pretty expensive. How are rural clients cared for with the DDC and in the legal setting?
We rely heavily on the GPs, really. The GPs are the eyes and ears for DDC, so if a client requires any treatment or assistance and they live very far, we can't reach them, we get them, first stop is to go and see your GP and get the advice, and they should know where to send you and would be happy to pay. So we provide, I guess, the monetary value as long as there's a supervising GP rurally that can assist them and tell them where to go.
Okay. And from a access to lawyers perspective?
We do have lawyers up there in Taree, and I did go and canvass a couple of the lawyers and see their expertise in what they can do for any of our patients. But with doing a mesothelioma course a few years ago, I definitely suggest the 3 lots of lawyers that are out there and explain to the patients that it's the lawyers that will come to them and they can sort things out for them. So I've been there where the lawyers have actually come up from Sydney and the patient's actually in bed really unwell, and have been there where they've actually been having the interview there with the patient. So we try to make it as equal as what it is in the metropolitan areas. I think we're pretty lucky in the rural areas where we're small enough to know a lot of the GPs and they feel comfortable with asking the oncology nurses if they can speak to the oncologist, but if not, we can give them some advice on where to get some help from as well. And we're across the road from our 3 physicians, so they quite often ring us and say, we're just about to tell a patient that he's got mesothelioma, are you able to come over? And we're there to give them all the information and go through everything straight up for that patient.
Now Karen and Chris, from your life, both as a palliative care nurse but previously as an oncology nurse, patients have therapies and they have side effects of those therapies, and if they're having odd and unusual side effects that they can't quite explain, is there a nurse that they can contact to discuss these issues with?
As a cancer care coordinator, patients have my number virtually from point of diagnosis. So they either ring myself and I'll get the answer for them, or guide them through where I contact accident emergency and get them to come into accident emergency if they need to be admitted. Also, our treatment room nurses are there for any treatment side effects as well. The palliative care nurses quite often will give me a ring if we're giving palliative chemotherapy to our patients, so we can keep the whole gamma of everyone all involved to try and help the patients and prevent them from having to come into hospital with any of these side effects if we can nip them in the bud at home.
Now, looking at I guess, more specific treatments, Brian, we know that you've obviously provided patients across New South Wales with great service from a surgical perspective over many, many years, but surgery remains controversial globally for mesothelioma. What do you see as the role of surgery in managing mesothelioma in 2018?
Well, there's three roles clearly defined on the algorithm. Firstly is to make the diagnosis, and I'm distraught to hear of those stories. Jocelyn, who works here at ADRI, but who worked with me for many years, more than most people get for murder in New South Wales, but we have a system. Anyone referred to me, we have it pre-booked, especially if they're coming from the country, that they see me on the Friday, and we have them booked in for the following week. And we cancel it if they don't need it. All of this can be overcome if you work with people in the field. So no one in the country should be disadvantaged other than they have to travel. And they have to travel sometimes to get the correct treatment. So if you want the correct radiotherapy following a pleuropneumonectomy or a radical pleurectomy, lung-preserving pleurectomy, you need to have it done with Momotin. Now, I don't have any problems with patients when you tell them that that's where you have the best treatment with them coming. The Dust Diseases Board, as I still call it, have been fabulous in that regard, provided I sign the form that they need to come down and have accommodation. It's all provided for, and the Dust Diseases Board have been exceptional in that. So, in the first instance for surgery, you should see a surgeon early to establish, one, a tissue diagnosis, not just for Armando and the lawyers, but so you know. That's what most people are worried about. They've been told all the other tests are negative, and I say to them, but they're not negative. You've got recurrent fluid of 600 mils there after it just drained last week. You know it's not negative. So early diagnosis. At the same time as the surgeon, if they're interested in this field, assesses as to whether they're suitable for ever being a case for pleuropneumonectomy. That's assessed at the first operation. And secondly, and thirdly, I should say, the most important thing is, and all the guidelines across the world, including the Australian guidelines, show get an effective pleurodesis is the single most important thing in the surgical management of mesothelioma and the management of mesothelioma. So it allows them to have all the other treatments that Stephen was touching on. The last thing about surgery is the radical nature of some surgery. And most people don't do it because most people don't do it. It's self-fulfilling. So certain units around Australia will say, we don't offer that. And I say, why don't you offer it? Well, we don't do it. Not, we shouldn't do it. They don't do it, so they don't do it. It's not, but if you look at the big units, Memorial Sloan Kettering, for example, where they're doing major surgery, it's based on a highly selective group, and the only discussion is whether you should do a pleuropneumonectomy or a lung-preserving pleurectomy decortication. Many years ago at this institution, we did lung-preserving decortications. We didn't give it that fancy name then, and we got the same results they're getting now. And that's why we took the next step in highly selected patients, and I emphasise it, highly selected, where that discussion you said about the toxicity of treatment is openly discussed, including death, include making them worse, that there is a distinct role for pleuropneumonectomy in a very subset of patients who need to be assessed by surgical units who do the operation, not by medical units who don't operate. And that's why it doesn't matter if you live in Timbuktu, you should be referred down for that decision in the major institutions. And I don't know of people who won't come for that assessment. I don't know it. I mean, my in-laws are all from the country, New South Wales, but if there's a medical problem of a major import like this, where it has to be in a unit that does enough, and it's not just for this, do you think you're going to have a liver transplantation in Dubbo or Taree? No, you're going to go and see the other Professor McCorn who runs liver transplantations at Royal Prince Alfred Hospital. And it's the same thing for mesothelioma. You want to come down into a unit that has been looking after it for many years, no matter where you live. And the support should and is being put around the patients, and I congratulate the Dust Disease Board on that.
Now, Brian, in those patients who do go on and get an EPP, and we've got a question from one of them today who has said, well, look, they're 6 weeks post completion of surgery and the subsequent radiotherapy, and they were a very, very fit patient going in, and now they're very tired. How long do is this normal to have this degree of fatigue after an operation like this and radiation, and how long can they expect it to go on for?
I'll let Momo talk about the radiotherapy as well, but it is the radiotherapy that makes them so worn out after this. Let's be clear though, these people go through hell for 6 months. So that's why they got a highly selected. There's no point having a pleural pneumonectomy if you're going to live 8 months. So you have 3 cycles of chemotherapy, a month off, a repeat scan to make sure the disease has responded or at least not progressed, a very big operation, a very destructive operation, but one well within our armamentarium. 6 weeks off, and then they see, or before then, but 6 weeks later, when everything's settled in terms of the movement of the mediastinum, which is the heart and the great vessels and the windpipe and the esophagus, you then go on and have 6 weeks of high-dose radiotherapy, targeted conformal radiotherapy, highly worked out to give it safely by Momo, and I'm not surprised they're exhausted at the end of it. So you've got to know or have a fair degree of assessment that these people, it is worth doing, because it is 6 months out of your life, and it's another 6 months getting over it. And we tell them all that up front. They mightn't hear it all. We tell them we may kill them doing that procedure. Now, our mortality is the lowest across the world, published mortality, and we're delighted, though, with the long-term survival in conjunction with Momo and Stephen's group, and now what we're seeing, the percentage of patients who are getting 2, 3 and 4 years, previously not described. So that's what we're aiming for. But it's a hell of a thing.
So Momo, what is the role for radiotherapy in mesothelioma? Is it just this radiotherapy after a big operation, or are there other opportunities for them to come and see you?
Essentially, there are 2 indications for radiotherapy. One is, we call it palliative, and which is essentially most patients who are having palliative radiotherapy will be on chemotherapy or maybe not unfit for chemotherapy, and essentially given to the site of disease where it is causing problem like pain or causing pressure to the nearby structures such as esophagus or spinal cord. So that's a short course of radiation, usually 2 to 3 weeks, because mesothelioma is not known to be very radiosensitive, so you got to give high dose to be beneficial. So, but in that sort of cases, short course and so not a lot of side effects, but it depends on where we radiate. Another indication for radiotherapy is following EPP, and as you mentioned in the introduction, we started doing that in 2004 with the standard conventional technique, and then we moved to intensity modulated radiotherapy. That's in like 2008, and we done almost about 80 patients, and it is a very complex radiotherapy. Everyone is different, and I'm still learning. I've done a lot, much more than anyone else in Australia, but I'm still learning because everyone's either right-sided tumor, left-sided tumor, their diaphragm may be in different positions, their residual lung may be big or small, their stomachs, there are a lot of organs to avoid radiation, and so it's very complex treatment. It's not a standardized treatment. We got a standardized radiotherapy plan, but radiotherapy, we call it target volume, is not standardized, and everyone is different. So I'm still learning, and we're still improving, and it is associated with a lot of side effects because patients gone through chemotherapy and surgery, and they're not lot of patients who started fit and well, by the time they reach radiotherapy, they're not really fit and well. And they've gone through another 6 weeks of treatment, so recovery can be months. And I think partly due to it's a large field radiation as well, and it's a nausea. Most common side effects are nausea and tiredness.
What other side effects can they expect, Momo? We've got a question here from a patient who feels as though they've had a flare of their dormant wisdom teeth during this time. Can we expect weird and wonderful things, or is it all pretty standardised?
No, it's usually radiation is within the field. So although you can get lethargy, that can be from different reasons, because there's some radiation, part of the liver is radiated on the left-sided tumors, and on the right-sided tumors, and the part of the stomach's within the field. So that's a lot of, you can have nausea and tiredness from that, but not wisdom teeth, not effect on wisdom teeth.
Sells herself a little bit short in terms of what she's done with the radiotherapy. If you look at the European experience, they actually lost people from radiation pneumonitis because they didn't plan and wait for the settling down I talked about. And Momo very carefully plans it. So they were irradiating in Europe the normal lung. So the patient with only one lung left was getting damaged. Momo's taken great care, and we haven't had one episode of that. So Momo puts great work into it. We discussed the planning based on what the extent of the surgery was. But Momo's done an amazing task with this. And our results in local control, which we were doing just the surgery to start with, when added the radiotherapy, our local control rate soared. In other words, improved.
Now, Momo, one of the concerns in the past had been that the tumour would track along the sites of where the ports had been in and drains had been in and things like that. And once upon a time, a lot of radiation was offered to try and stop that from happening. Now, in some centres, that still happens now. What's the current guidelines? Because it seems to confuse a lot of patients.
It's interesting because I just came back from a large, big radiotherapy meeting in Europe, and I'm actually doing a journal club presentation tomorrow. And that meeting presented a large, another randomized trial on port-side radiotherapy. We call it the radiotherapy to the scar. And there has been 3 randomized trials prior to that, but only about 50 patients each. But this one from UK got about 200 patients, and clearly showed that there's no evidence that radiotherapy is beneficial in these.
So it's dead in the water now?
Yes, so it should be, there should not be any more trials about that.
Well, you'd have to ask why they're giving it other than medical reasons.
Okay. So Karen Selman is a patient care representative, and how can patients and carers access support clinically and information in the community?
Patients can actually ring support. There's a couple of support networks available. There's obviously our support network here at ADRI, where we provide telephone service. Jocelyn and myself, we have a database of patients that are diagnosed so that we actually can ring patients, finding out how they're going. The carers can actually speak to us as well. The carers can actually call us if they have any problems. We also provide support groups as well. So we've got just a general support group that runs in the Liverpool area, in Revesby Workers Club. That's for anybody in Sydney can attend. We also have the EPP group. They meet 3 times a year, patients that have had the surgery, and that's a fantastic group. Actually, it's very inspiring to see all these patients. And we also have a bereavement group as well, which is quite rare. I don't think any of the other organisation support groups provide the bereavement where people, carers can come to either here to ADRI, or we have a certain area that we meet and just have a chat. And we also speak to carers that lost their loved ones over the phone. They actually find that really helpful, I think, because I think that what they find that once their partner has passed away, everything stops, and they don't get the care. Well, not the care, they don't get the support that they used to have before. So the fact that we give just a quick phone call to see how they're going is quite helpful, actually. So, yeah.
And I think we should obviously put in thanks for the kind of work that Karen and Jocelyn do. A number of us are on the circuit of these things, so to speak, and I think it's important to say that because mesothelioma is a relatively niche malignancy, there's not as much information out there as sometimes we would hope available to patients. So certainly putting on forums such as this ends up being a real opportunity for people to hear from experts who this is their bread and butter, rather than a random patient here or there.
That's right, and to have it being able to do a webcast as well, because we get quite a lot of patients in the rural and also interstate. We get a lot of patients from Queensland that come down to Sydney for treatment. So just to be able to have something that they can watch and also have all these panel of experts in one place at the one time is just fantastic.
So that's the end of, I guess, our formal questions that we had, but obviously we'd ask anyone in the audience if they had any specific questions, and there is a mic that will be floating through.
Yes, I have a question. If surgery is not an option for a patient diagnosed with mesothelioma, what are the most effective? What's the normal path then for treatment?
Sure. I'll answer this in conjunction with Stephen, because I would have that discussion with the patient. I presumably he'd operate on to make a diagnosis and to do a talc pleurodesis, which is the critical part of the management. So having done that and having made a decision for whatever reason, whether it's their condition, their general cardiorespiratory function, and we make this decision before the patient goes to Stephen. This is a really important issue that based on what I've seen and felt at thoracoscopy and the biopsy and the cardiorespiratory status, I make a decision that I put in the letter to Stephen. This patient is or is not a candidate for radical surgery subsequent to chemotherapy. Of course, they all have chemotherapy first, right? So before going on to a radical surgery. So then I suggest they talk to Stephen or one of his colleagues about the role of chemotherapy in those that I have said would never be a surgical candidate. And you've got to make that decision early. You've got to make it then. So they then go and see Stephen, and he discusses, as he'll talk about, whether they have chemotherapy then or a period of observation to see the pattern of their disease. As I've said to you, I've seen patients before who've just rumbled on for years. We've equally seen the bushfire form of the disease. Probably neither of them benefit from chemotherapy. It's the ones in the middle, and that's what Stephen discusses, as I have a preliminary discussion as to whether to wait and see what's going on in your life at the moment, or do you go to chemo there and then?
Look, so I guess one thing to remember is that with all the literature and clinical trials, that chemotherapy, as I said back in 2003, has been proven to prolong patients' life, as well as improving patients' quality of life with the standard chemotherapy that we offer our patients. But in a 40% proportion of patients. Now, I guess if they're not suitable for surgery, then I think quality of life is very important to consider. And the second thing to remember is that, as we've all talked about, the prognosis is extremely variable. We've all had patients who have done extremely well with no treatment. So I've had patients whom I've observed for 2 or 3 years before they need any form of chemotherapy. And again, that can occur in up to 10-20% of patients where, treatment up front may not be the best thing to do. So there's a couple of guiding principles. One is that if the cancer bulk is relatively large, meaning that the thickening is quite significant, then I think I will be more recommending towards having some chemotherapy sooner rather than later. The second thing is how symptomatic patients are. So if they are completely asymptomatic and they're getting on with their life and they've got holidays to go to and things like that, then I think a period of observation would be completely appropriate. Whereas if somebody has large volume disease and they have pain or shortness of breath, then I think observation probably wouldn't be the best thing to do there and then, in which case I will suggest a course of chemotherapy first. But it's really a discussion about what the potential benefit and potential side effects of that would be. But that would be my kind of general principle.
And how would you recognize the bushfire type? What generally happens with that when it's that?
Chest X-ray alone will tell you.
Beg your pardon?
A chest X-ray alone, 6 weeks after the diagnosis, will show how far it's multiplied. The patient will reflect it as well in their condition. Can I just add to Stephen's comments on what I said was all of our mesothelioma patients are discussed at our weekly MDT with all the specialists present. So none of us think we're an island in this. We all make decisions based on each other.
I'm sorry if this becomes a little subjective because inevitably, as a patient, one thinks about one's own situation. But I was diagnosed in June of last year, and everything was supposed to be fairly quiet. And then, because I needed a new pacemaker, it was discovered that I had a lot more fluid, so I had a talic pleurodesis in October. And the symptoms have been fairly quiet, but quite recently I'm getting a lot more breathless, for example. And I'm wondering if the bushfire can lie dormant and then flare up.
No, I don't want to misguide. You haven't got the bushfire. You're sitting there still. I assure you haven't got that. What you carefully need, talc pleurodesis does not work in all cases. It's by far the best pleurodesis to do first up. But on our algorithm, we have a spot for you, and that is if the fluid comes back, and I'm not saying you have, but you need X-ray or CT, you may then have an operation, pleurectomy, not the big operation, but one to control the fluid. Because let there be no doubt, the thing that will determine people's medium-term outlook is the control of fluid around the lung, no matter what. Stephen does not want to see patients for chemo if they have recurring pleural effusions till we fix that. So you need...
You can get that even if you had the pleurodesis?
Yes.
Mm-hmm. Okay, thank you.
We've done a number of those, and that's part of our algorithm, that if it doesn't work, and it's not that the person didn't do it correctly, sometimes it's the tumour burden. To have a pleurodesis getting the two surfaces to stick, you have to have some normal surfaces to stick together. So if there's a tumour bulk, sometimes you have to do a debulking pleurectomy to allow for a pleurodesis. Slightly bigger operation, very low mortality, a little bit more pain than a thoracoscopic pleurodesis.
Thank you.
I think you brought up a very important issue as well. Just because if we decided to do observation, it doesn't mean that we leave you alone. So I think, regular scans, regular review is very important to see how the cancer is going so that we don't miss this bushfire, or significant progression while we're watching you. So I think regular scan is important. And also, just because we do regular scan, it doesn't mean that something wouldn't happen between the scans, and that's the other important thing that I always tell my patients, that during between the scans or between the visits with me, it's important that you contact us if things are not quite right. So if you have more shortness of breath, contact your treating oncologist so that they can see you sooner, so that we can determine whether an extra X-ray or unscheduled CT is required, so that we can, treat that.
Just one thing on country patients I think we should emphasise, because I really appreciated the words from Tari and Manning. And Momo just reminded me, because this self-fulfilling thing, we don't do pleuropneumonectomy, so we don't do them, we've had patients from every state come to our institution for pleuropneumonectomy. They then come back for the radiotherapy, because that's an integral part of it. Momo does give the radiotherapy. We should touch on your question, what if surgery is not on, because there was a radiation oncologist in Melbourne who was very keen on high-dose radiotherapy as an alternative. Some of my patients, in fact, one was due to have a pleuropneumonectomy on a Tuesday morning. My theatre list for the day was decimated when he decided to leave the hospital and not have it. He went and sought that advice in Melbourne. ultimately came back and had the surgery and is still alive on marijuana. And he's doing extremely well, but it is important that people have put out that radiotherapy can be used in this radical way. I think it's true to say at point of time now that's not accepted wisdom in terms of that. But some people would seek that out. And we have to always be careful of the charlatans out there. There used to be someone in Western Australia that gave microwave treatment at extremely high cost. So you must be very careful. We know, all of us in conventional medicine, know all of our patients with meso seek alternative therapies. There's no doubt, all of them do. And my very dear close friend Chris O'Brien, who wrote Never Say Die, the head and neck surgeon who had a brain cancer, he in his book explored how he and his wife went to look for every alternative therapy, although he was a conventional cancer surgeon. So alternative therapies I have no problem with as long as, one, they don't do you any harm, and B, it's not someone just ripping you off financially, and we've all seen examples of that. But if you're going to have alternative therapy, just tell us. I had one patient who bled to death because she didn't tell us of the drugs she'd gone out and had in naturopathic medicines. The naturopathic medicine have some terrible drugs in them if you operate. But we accept that people all seek alternative therapies and there's nothing wrong with it.
I have to add something now. Firstly, there's, if you're in the watch and wait time, that means that you're watching, waiting and exercising and eating well and really caring, changing your lifestyle to stay as well as possible every day. It doesn't mean sitting around waiting, so that's number one, because the fitter you are and the better you are, the better you're going to tolerate future treatment and you'll live better and maybe longer. And Jane would, prescribe a good exercise program. The second thing is there's just a distinction to qualify this slightly between alternative medicine and complementary therapies. Complementary therapies are adjuvant to, as well as the disease-modifying treatment, the standard therapies. There are, and being very specific with herbs and supplements, because there are some herbs and supplements that have quite a few side effects, and there are other therapies that can be helpful for symptom management, like acupuncture and massage and other treatments, and meditation, as well as some selected herbs and supplements. So doing both is basically, do it all, but do it carefully and monitored well. That's the, and look after your psychological well-being. I noticed we don't have a psychologist here in the group or a social worker, so that was one thing that I thought that when you're sitting and watching and waiting and anxious about what's going to happen next, when should I have surgery, when should I not have surgery, the stress of that is quite horrific, and being really active in seeking some support and developing coping skills to be able to manage the psychological and the social impact of having disease is incredibly important.
So what would trigger the move from watch and wait to intervention? Is there some sort of indicator there that would say, right, we've arrived at the time, my pleura has thickened a little bit in the last few months, and it was suggested, and I'll throw this on the table, though it was rather shocking at the time, that I've got a 30% chance of living 2 years. And so my question is, well, should an intervention have already happened, or is it time? When does one intervene? So
So again, I think it's the same consideration that I make. One is how symptomatic you are, because as I said, chemotherapy can improve mesothelioma-related symptoms and therefore improve their quality of life. So if you started to develop a lot of pain or started to be more breathless and your fluid is still controlled, then I think that's a pretty good reason to think about starting chemotherapy. Similarly, radiologically, if your CT scan shows that within 3 months the thickening has significantly increased or there's new spots, then I think, again, that will be another kind of medical reason to start chemotherapy as well.
Thank you.
In terms of how long you're going to live, I'd repeat my advice earlier. Yeah, doctors don't decide how long you live. You look particularly well at the moment, and just stay that way. I support all the supportive exercise. Before we had a limpter, I used to speak to the patients like you asked me if there was no surgery, before we had a limpter. And I used to say, there's 3 A's. Jocelyn will attest to this when she worked with me. I used to talk to the patients about the 3 A's, which the patients had taught me. Medical school hadn't taught me. Having a fellowship at the College of Surgeons hadn't taught me, but the patients taught me the 3 A's, and that was activity. This was going back pre-2000. Activity. I said, you don't have to become a veteran triathlete, but you've got to keep moving. Appetite, by which I meant calories, and I said the dietitians will swear at me because all you need is calories. You'll have a balanced diet as well, but eat all the stuff that tastes good, whatever you want, alcohol, do it, right? And attitude. Yes. And that's the mental state, Judith, that I always emphasised. And that's, in my mother's case, was what drove her for so long. The 4th A came along, as Stephen has touched on, when a limpter became available, and we finally had a drug combination that had an effect. Before then, it was all random, but we had an effect. So it is still the 4 A's are a critical part. And now we have all these new things, and you should just stay in touch with your oncologist for when they're right for you.
It's very hard to exercise, though, if you've got shortness of breath. We bought a walking machine. And,
you can do it. The greatest study of that about exercise, before this new stuff came out, the greatest stuff came out was a Commonwealth program for aged care, not cancer patients, just aged care patients in Hornsby Hospital. And it was run by a geriatrician, and they employed 2 lowest paid nursing assistants and they had to walk the geriatric patients every day. They had no choice, the patients. It's a real surgical motto, I'm informed, you give consent. I mean, they walked them every day. The length of stay plummeted and they weren't allowed to say no, they were exercised every day, such that when the program ran out of Commonwealth funding, Hornsby Hospital funded more nurses to do it, because exercise is so important, not just in cancer, but in all health. And it was a fabulous model to go back to in terms of how important it is. You just have to do it.
I'll add my bit in that as well. It's much easier for us to say that you need to exercise and this is how much you need to do and this is the best type of exercise that is right for you right now. But when you are tired and when you are short of breath and, sometimes exercise makes you more short of breath or more tired, it's hard to then try and stick to that routine. So, when we go, I'll add more onto that motivation question from before. So I think it's, yes, you do need to be motivated to be active, but it's also switching more to a robust form of therapy now as well. So exercise is, we can dose exercise like you would dose a type of medication or chemotherapy that you might take. And we do have optimal dosages of exercise for different things, and things like shortness of breath and fatigue and different types of cancer. But that's something that an exercise professional would help you build up towards that optimal dose. And so everyone has their own personal start point baseline based on what your exercise background is, what you do now, what your side effects from treatment are. And they help you start so you're at least doing something as opposed to doing nothing. And I think that's also the key. Something is better than nothing and more is better than less, but people are there to help you in the right direction so you can keep moving forward and avoid being inactive.
We do walk every day. We drive to the top of a hill and walk down.
Excellent.
The other great evidence of exercise comes from a group of patients whose daily life is shortness of breath, and that's people with chronic obstructive pulmonary disease. who daily live. This is the Marlborough man you don't see. You know, the Marlborough man you think of getting cancer. The worst thing you get from smoking, in terms of quality of life, is this terrible shortness of breath. They have Dave McKenzie, a respiratory physician out in the southeast, has demonstrated how you can reduce the number of readmissions for complications of their chronic obstructive disease by graduated, targeted, dose-related treatment in terms of walking or getting on a bicycle, actually. And they'll even put them on a bicycle short of wind with oxygen, if that's what they need. And these people's lives through exercise have been made incredibly different. So we have all the evidence, and I agree totally about dosing it up with an expert. And it's for us to get people to people like that. But I've just seen it repeatedly, people who've got on with their life, as I like to call it, in terms of all those things you've heard so eloquently put today.
Any other questions?
Am I on? My name is Sharon, and we're walking this mesothelioma road. And we had a diagnosis in August, September last year. So far, with a bit of background for you, we've followed conventional therapies. We've had pleurodesis and the biopsies and chemotherapy, 6 cycles of chemo, 3 cycles of the radiotherapy, 3 treatments rather, short treatments, and an attempted EPP just 4 weeks ago. So this is recovering from that still. It couldn't go ahead. We've made a claim through Comcare. So my question is, and we're just learning as we go, at this point in time, there's been so much spoken about from that end of the row, the ladies and gentlemen who are caring for the patient in other ways and their well-being, assistance in many other areas. I don't know what's available to us as Comcare people. Are we able to get assistance in that area, and certainly when it becomes more necessary as the disease progresses, or are we precluded from any extra care that may be available in our situation?
I'm surprised that you've immediately made a claim through Comcare, and I don't know if you've actually explored other rights, but Comcare is a vast statutory scheme. It has the same types of benefits as what are available through the Dust Diseases Board. The difference really is that you don't get the sort of expertise, specialist expertise that you get through the Dust Diseases Board, but the statutory provisions are wide enough that you should be able to get those sorts of support services that you can get through the board, and you should be able to get them through Comcare on application.
So it would seem that there's a step further that we need to take?
Shouldn't be. It should be through Comcare. You should be able to get all of the type of medical assistance that you might want. I don't know if Comcare will take the same approach to immunotherapy as the Dust Diseases Board take. The Dust Diseases Board say, look, if this is reasonable and necessary treatment supported by a letter from the treating oncologist, we pay for immunotherapy. I don't know what Comcare's position is going to be to that. But the Dust Diseases Board was activated by people making claims in relation to immunotherapy to ultimately adopt that policy. You may need to get Comcare to do that.
Just the background, I was employed by the Commonwealth Government, by Commonwealth authority, and that's why the advice given to me was that my claim would go through Comcare rather than the Dust Diseases Board. That claim then went to mediation, and the mediation has been settled. And my understanding is the settlement is final. At the time, I was and still am happy with the settlement figure, but I'm now hearing, and my wife's hearing, of other services that are provided by the Dust Diseases Board.
Okay, now the last bit's the bit that I wasn't aware of. If you've settled your Comcare claim, you've brought all your rights under the Act to an end. You have no further rights. Your wife will have rights in due course, but you have no further rights now. You've extinguished them by making the common law claim, and hopefully all of the sorts of things that you might need were taken into account when the claim was settled.
Yes, hopefully. In hindsight, was that the right decision to make a claim through Comcare? As my advice was, having worked and been exposed to asbestos through employment, Commonwealth Government employment, that was the only path open to me.
As long as the settlement was all-encompassing, the answer to that question is undoubtedly yes.
And you still have...
And you've said you're happy, so that's the really important
Well, the settlement was for specific figures for specific treatments, and then an amount based on loss of superannuation.
Yeah, it sounds to me like you got a good outcome, and the important thing about legal outcomes, they're the same as medical outcomes. The critical thing is that the patient, the client, is happy with the outcome that they have received. That's the most important thing in the world.
What you do have is you have access to the local palliative care services and community support services, which means you can have access to occupational therapists, physiotherapists, good specialists, nursing care, all and whatever equipment you need in your home, and they work together with you to work out what is helpful for you to maintain the best quality of life at home, and that's accessed locally. Depending on where you live, the services are slightly different, and usually that's either free or very minimal rental costs for certain equipment. So you're not disadvantaged in that way. It's just combining different services in different ways.
And is that access through my local hospital or?
Yeah, your GP.
Or my
your GP can make the
GP.
referral to the local service or your specialist.
Yeah, okay, thank you.
Just say from a rural perspective, again, I just say that anyone can refer to our palliative care team. So we try to get them in as quick as possible for any equipment that they need at home.
I have time for one more question.
Yeah, I have a few questions. I was diagnosed last year and had pleurodesis. And I just wonder how the body gets rid of the fluid. Or is it just going to build up again?
It's almost universally, and it's not only for mesothelioma that patients get fluid around the lung. There are lots of other cancers, and it's the commonest question asking me, where does the fluid go? Anywhere in the body in which there's a cavity left will fill with fluid. You never have a cavity in the body, whether it's in the tummy, the brain, or the chest, anywhere. If a cavity forms, it fills with the normal body fluids. So that's even normal. So the aim in a pleurodesis for mesothelioma is to obliterate the cavity. And you obliterate the cavity by getting the two surfaces of the pleura to stick together, and there's no cavity for fluid to form in. And that's how it works. So if it works at a week, it's basically worked. It's this sticking of those two surfaces, because all of us, every one of us in this room, and those that have meso on one side, on the other side, have a very thin layer of fluid around the lung. The fluid's being made and absorbed every minute of the day. And teleologically, the aim of that is to make breathing more easily, because the lung moves much more easily over the ribs. You don't need that fluid, and we know many patients who've had pleuritis in the pleuritis in the past who don't have it, pleurisy. The first thing that happens when you get a malignancy in there, the fluid doesn't get absorbed. So your own fluid starts to build up. The second thing that happens is the cancer actually makes fluid. So the aim of pleurodesis is to obliterate the space and the fluid doesn't come back. It doesn't get made.
My last CT scan, the oncologist said the disease is now stable.
Good.
And I only need to go back in 3 months. At what stage would I be able to get immunotherapy if it does alter? Or do I do it while it's stable?
Look, I think again it goes back to that variable prognosis. So I've had patients who have had chemotherapy and 3 years later they're stable still with regular 3-monthly scans. So in that situation, you know, if you rushed into immunotherapy, we would have all gone, hooray, immunotherapy is working. But in fact, it's what the chemotherapy has done, and that, you know, you've just got a good disease. So for that reason, our guiding principle is that we keep an eye on you, regular scans, and should the cancer start to grow again, that's when we think about our next step, what will be the best thing. And if that next best thing is immunotherapy, I'm sure your oncologist will suggest that. But that's what I would typically do.
Basically saying you wait for it to become active before you progress to that.
Right.
I had one last question. Just there was a mention of further surgery if it gets worse. And was that removing the lung? And would there be any chance of the opposite lung being infected?
The opposite lung will be affected if you live long enough. It's not usually a problem. There's no doubt that the asbestos body that you've inhaled are on both sides of the lung. It's just like smoking. The smoke goes in, of course it's through both lungs, but you get a lung cancer in one or other lungs the first time. It's like skin cancers, you often get one there, a couple of years later one there. So it can affect the other lung. It's rarely a clinical problem, but I have had a number of patients in whom we did a pleuropneumonectomy on one side and they lived a long time and got meso either on the other side or, as you can get it, peritoneal in your abdomen, mesothelioma. In terms of surgery I mentioned, if the pleurodesis doesn't work and fluid's recurring, you can do a bigger operation called a pleurectomy, which works in 99% of cases. Yes.
I have read somewhere about if there is fluid return, sometimes they can put a drain in.
Yes.
And you can collect the fluid.
Yes, you can. Yes, if you like a drain for as long as you live, that's the Western Australian approach. Where they're very keen on drains. We use it selectively in patients who aren't fit to have anything further done. It can be a useful adjunct. You do put a drain in and you evacuate fluid into a little plastic container every day that you throw away. I've seen patients from Western Australia who've had that in for up to 10 to 12 weeks and in fact went on and had a pleuropneumonectomy, which was the appropriate treatment in them. But in some patients, and it's not just for mesothelioma, but the other form of cancer, the lining of the lung, it can be effective. It's not something that I think should be overdone.
I think we need to wrap things up now. So I would like to thank Anthony Linton for moderating our session, and I won't individually thank individuals within the panel, but thank you for your contribution. It's not very often that we see people giving their time, clinical experts giving their time to this sort of thing. So we really, really appreciate it. If there are any other questions that people who might be listening in would like to forward, please just go to ADRI's website, adri.org.au, find the link to us, and Karen and I will get back to you with any answers. So thank you so much, everybody, for attending.